All right, our next speaker, Dr. Malika Gupta Lewis, MD, FAAP, is going to be giving us a talk titled Best Approaches to Diagnosis and Treatment of Primary Immune Deficiency. Dr. Gupta Lewis is from Hoag Medical Group. She sees children and adults. She treats them like family members, that she believes that patients in her practice should feel like family members of the practice, just as we in concierge medicine feel it. So she's got that concierge medicine attitude. She's an allergist and immunologist for Hoag Medical Group. Some common conditions she treats, of course, include food allergies and asthma, and eczema, and hay fever, sinus disease, drug allergies, food allergies. And after graduating from medical school, Dr. Gupta completed her pediatric residency at Virginia Commonwealth University and then proceeded with 2 allergy and immunology fellowships, first at Starship Children's Hospital in Auckland, New Zealand, a tertiary care referral center for the country's food allergies and primary immunodeficiency problems in children. And then she trained in both pediatrics and adult allergy and immunology at the University of California, Irvine, in Irvine, California. And so please welcome Dr. Gupta Lewis.
Thank you. Can you guys hear me okay? Is it on? Yeah? Okay, cool. All right, thank you so much for having me today. I'm delighted to be here. Thank you for the introduction. So I'm a private practice allergist and immunologist. My practice is about 50% allergy, 50% immune deficiency. Primary immune deficiencies are very near and dear to my heart, so I'm thrilled to be able to speak to you about them today. Now, just kind of so I get a feel for the room, how many of you guys see pediatrics? 0, 1, 2. Okay, all right, cool. So then we can talk about that a little bit. All right, so here's my disclosure slide. And our objectives today, so we're gonna do a quick immunology one-on-one, then we'll go through a couple of cases, a couple of algorithms, and then we'll talk about therapy. So the immune system, this is derived from the term immunity, meaning immunitas. So this refers to back in the day where senators were basically immune from prosecution. And so what we're doing is we're protecting our body in a lot of different ways. So the immune system basically functions to not only control infections, but also to identify self from non-self. So this is involved in fighting cancer, autoimmunity, and in allergies too. So we have to think about this globally. All right, so when the immune system doesn't work, what happens is we see things like infections, allergies, autoimmunity, and cancer. So remember that patients with primary immune deficiencies can present in all these different ways. So let's do a little bit of immunology one-on-one, going back. So we have 2 arms of the immune system, the innate immune system and the adaptive immune system. The innate immune system, so this was basically the most primitive. It's our first line of defense. We have no memory response. This is completely non-specific. And a lot of focus on defense against viruses and cancer. The adaptive arm, in contrast, developed later. This is important because it's our second line of defense, and the key features here are that we have memory responses, it's specific, and we can defend against all microbes. Okay, and one of the main things I want you to remember is the discrimination between self and non-self. That's important here. All right, so in the initial hours after an infection, you've got the innate immune system that kicks in. Key players here include phagocytes, dendritic cells, the complement system, and natural killer cells. As the infection progresses, then you have T cells and B cells. So B cells are our antibody-producing cells, and T cells basically will help the B cells do their job and help with memory response. So going in a little bit more detail with regards to the innate immune system, natural killer cells function to kill viruses and cancer. Dendritic cells help to shape the immune system. So these are antigen-producing cells. What they do is they grab up foreign foreign antigens, they eat them up, they present them to T cells and B cells in the lymph node, thereby shaping the immune system. Monocytes and macrophages function in phagocytosis to kill bacteria. Neutrophils kill both bacteria and fungi, and I want you to remember the fungal aspect there, and then complement basically massive amounts of inflammation. Adaptive immunity. So here we have our T cells and our B cells. T cells are designated by cluster differentiation 3, CD3, and B cells by CD19 and CD20. T cells are then split into CD4 and CD8 positive cells, which kind of help us to understand, are they killer cells or are they helper cells? Meaning, are they helping B cells do their job, and are they functioning more on like fighting viruses and cancer, or are they fighting bacteria and then contributing to allergies? B cells help to defend against bacteria and viruses. All right, so how do our antibodies function? So our antibodies function in a lot of different ways. Briefly, they help us to fight microbes, neutralize toxins. They help us to opsonize microbes. So basically, they make microbes tastier so that they're able to be more attractive to phagocytic cells. They also help with antibody-dependent cellular cytotoxicity. So what happens here is we have a microbe in which an IgG antibody is attached to, and this brings it closer to an effector cell, in this case a natural killer cell, and allows the natural killer cell to then kill that microbe. And then antibodies are also strong activators of complement. So basically, they'll bind to different components of complement and then recruit inflammatory cells and then help to fight infection that way, or create an inflammatory response in that way. Different types of immune globulins. So IgG, IgA, IgM, IgE, and IgD. Today we're just going to focus on G, A, M, and E. Easy way to remember, it spells out game. All right, so IgM. This is the first antibody to be made after you have an infection or after you're vaccinated, right? It signifies an acute infection or reactivation of infection. It's most commonly found in the serum and a little bit in tissue, and it activates complement strongly, especially because we know that IgM is a pentamer. So just think about 5 different arms able to bind up complement stronger than most other antibodies. It makes up 6% of the immunoglobulins in the blood, and its half-life is about 5 days. IgG, so this is the most amount of antibodies that we have, makes up about 80% of our antibodies. It's found in blood and in tissue, helps us to fight bacteria and viruses, and is important in the memory response. It's our memory antibody. This is also the antibody that's transferred from the mother to the fetus, and this is because it's a lot smaller than the pentameric IgM, for example. There are 4 subclasses of IgG, IgG 1, 2, 3, and 4, easy to remember, and the half-life is about 3 weeks. Note, though, that IgG subclass 3 has the shortest half-life, which is about 7 days. IgA. So this antibody protects against bacterial infections. It prevents bacteria from attaching to gut epithelia. It also facilitates phagocytes to do their job better. So basically, degranulation of phagocytes and production of superoxide, which we're going to talk about later. So just kind of keep that in the back of your head. It also inhibits TNF-alpha and IL-6, which are 2 important pro-inflammatory molecules. IgA1 is found in the serum and the respiratory tract, and IgA2 is found in the GI tract. IgE, everybody knows about this, in first world countries helps us to fight, or helps basically bring about allergic disease, and in developing countries, parasitic defense. The half-life is 2 days, and it makes up a very small amount of total antibody numbers. So why do we care about our antibodies and primary immune deficiencies? This is because If we can diagnose primary immune deficiencies, we can actually cure some of them and then treat the ones that we can't cure effectively, thereby improving the quality of life of our patients. Many of them actually we can find prenatally or with the newborn screen. So there are over 11 states in the United States that actually newborn screen for SCID. California is one of them. Unfortunately, Nevada is not. But there is a scientist in San Francisco, her name's Jennifer Puck, you guys may know her, who basically initiated all of this and started the newborn screening in the United States. So we've now been able to diagnose and actually transplant a lot of these babies who were born with primary immune deficiencies. If we're diagnosing them prenatally, we're able to provide genetic counseling for families. And one of the main things that I want you guys to take home today is that primary immune deficiencies are not as rare as you think they are. So about 500 new cases per year in the United States, about 10 million worldwide. There's a number of different primary immune deficiencies, over 400 genes. The big thing here is that primary immune deficiencies are actually 4 times more common than hemophilia, 3 times more common than cystic fibrosis, twice as common as childhood leukemia and lymphoma combined, and as common as multiple sclerosis in the United States. The problem is that they are so poorly diagnosed that it takes an average of 10 to 20 years from the onset of symptoms to diagnosis. So if you remember nothing else from today, just remember that. Primary immune deficiencies can occur in both children and adults. In children, they're typically more severe. They're considered immunologic emergencies. They need to be treated, transplanted, etc. In adults, they tend to be a little bit less severe. The most common is common variable immune deficiency. Common, meaning it's common. Variable, variable in presentation, whether it be recurrent infections, autoimmune disease, GI disease, and immune deficiency. Primary immune deficiencies, contrary to popular belief, are actually infections with common bacteria or viruses, not necessarily always opportunistic infections. These infections are typically serious, so you'll get infections with common things, but they'll have a more serious course, sepsis, inpatient stays, IV antibiotics. And in general, you'll find that these patients respond poorly to antibiotic therapy. These are patients that are getting antibiotic course after antibiotic course. The patients that are calling you every other week, I just finished my antibiotics, but I still don't feel well. So remember that. I'm sure you run into patients like this in your practice. So once again, when the immune system doesn't work well, it's going to not work well in a lot of different ways. So you're going to have different presentations: autoimmunity, inflammatory problems, allergic problems, recurrent infections. The different types of infections that you get can actually clue us into what types of defects we have in the immune system. The most common immune deficiencies tend to be antibody deficiencies, and then the second most common tend to be a combination of both B-cell and T-cell deficiencies. So this is kind of like an interesting way to approach this and might help you out in clinical practice. So if you have patients who have recurrent infections with staph, strep, Haemophilus, think B-cell disorders, antibody disorders. Remember, our B-cells are antibody-producing cells. If you have patients who are having infections with intracellular microbes, CMV, herpes, measles, Candida, Aspergillus, Mycobacterium, Listeria, Pneumocystis, think T cells. If you have patients with Neisseria, and if you ever see Neisseria meningitis and you don't check complement, we've missed everything here. So Neisseria meningitis, check your complement. Complements, remember, important in inflammation, so also important in viral infections as well. Phagocytes, think infections with staph, gram-negative bacteria, fungal organisms, Serratia, Burkholderia, Klebsiella, think monocytes, macrophages, neutrophils. All right, so when are we going to think about primary immune deficiencies? In patients with recurrent sinus infections, lung infections, patients with chronic deep-seated abscesses, whether it be skin abscesses, liver abscesses, lung abscesses, patients with repeated infections with the same organism. Why does this patient keep calling with like recurrent strep pharyngitis? Every single 3 to 4 months, I rapid strep them and it's coming up positive with the same exact organism. These are red flags for you. These patients, once again, respond poorly to antibiotics. It takes a while for their immune system to get kick-started. They're requiring more and more antibiotics with longer and longer courses. Unusual and opportunistic infections, of course, can happen, and that's to be expected. Often these patients will have a history of someone in their family that was sick all the time, someone who was always coughing, someone who was always in the hospital, someone who was always on antibiotics. In children, we may see, especially with combined or T-cell defects, failure to thrive, poor growth. And then also, if on physical exam you're noticing absent or low number of lymph nodes and lymphoid tissue, that's a red flag also. So here's a case. You may have seen this person in your office as early as Friday. So a 30-year-old female presents with a history of recurrent sinus infections. These infections were treated with recurrent, frequent, prolonged courses of antibiotics to moderate effect. She's been hospitalized with pneumonia twice in the last 5 years, and she has a family history of siblings with recurrent sinus infections and atopic disease. On lab evaluation, so you did a CBC with diff, it was normal. You went in, you did a lymphocyte subset. Your T cells are normal, but your B cell numbers are decreased. Specific antibody response to Pneumovax is poor. What does this mean? So what happens is, when we're doing the evaluation, we look at baseline pneumococcal antibody titers. You can order this at any lab, Quest, LabCorp, whatever else you have out here. You're looking for the 23 serotypes at baseline, okay? The standard is if your baseline numbers are less than 2, those are considered unprotected. Then you vaccinate with Pneumovax. Why do we vaccinate with Pneumovax? Because we're looking for a pure polysaccharide vaccine. This is because we're trying to isolate our B cells and understand B cell function. If we use Prevnar, we're actually recruiting T cell help and we can't analyze B cell function. So we use Pneumovax. 4 weeks after vaccination, we redraw our pneumococcal antibody titers and we compare our pre-vaccination titers to our post-vaccination titers. We're essentially looking for a 4-fold rise in greater than 50% from pre to post-vaccination. This is sort of like a, yep. It's a really good question, and that's where it gets a little bit confusing. So it depends on how long ago they were immunized. So typically, vaccinations with Pneumovax should provide protection for about 5 years. Many times in patients who have specific antibody deficiency, meaning that their B cell function is poor, what we'll find is that despite vaccination, if you check titers, many of their numbers will be less than 2. Often more than 50% will be less than 2. And that's essentially telling us that either they didn't mount a proper response, because we often don't check post-vaccination, right? Or they didn't maintain memory to that. And we can talk more about that later if you like. So in this patient, when we compared pre-vaccination to post-vaccination titers, more than 50% didn't have a 4-fold rise. Additionally, she had panhypogam, so her IgG was low, IgA was low, and IgM was low. So this gives us a diagnosis of common variable immune deficiency. Easy thing to remember with common variable immune deficiency, you usually have 2 antibodies that are low, typically IgG and IgA, or IgM in this patient, all 3, and that's because her B cell numbers are low, right? And you have to have a poor vaccine response to Pneumovax. So specific antibody deficiency. You need those two things to be able to diagnose common variable immune deficiency. Does that make sense to everybody? All right, so common variable immune deficiency can, as I mentioned, have variable presentation. So it can present with recurrent lung infections, so with staph, strep, Haemophilus, Moraxella. It can present with GI manifestations, so infections with Salmonella, Campylobacter, Giardia. It can present with malignancies, breast cancer, gastric cancers, non-Hodgkin's, Hodgkin's lymphoma. You can also see commonly hepatosplenomegaly. You'll see non-specific GI complaints. So people who have been diagnosed with IBS or IBD, malabsorption, chronic diarrhea, and then patients that also present with hemolytic anemias or ITP, rheumatoid arthritis. So variable presentation is what I want you to take away from. Say that one more time. Not a lot, but you can see it, yes. All right. So primary immune deficiencies in adults, when we see deficiencies in adaptive immunity, common diagnoses include XLA. So this is typically found in young boys, so X-linked, after maternal antibodies have waned, so after about 4 months of age. A common variable we just touched on, IgG subclass deficiency, typically IgG 1, 2, or 3. What we're learning about IgG subclass deficiencies is these patients are often presenting either with chronic urticaria and recurrent infections or other forms of dermatitis and recurrent infections. Selective IgA deficiency, selective IgM deficiency, this is one of the newest ones that's been added to the ICD-10 diagnosis, and these patients often present with atopic disease plus recurrent infections. Hyper IgM, a lot of cholangitis, hepatosplenomegaly, specific antibody deficiencies. So that's when you have normal number of antibodies, but poor vaccine response, and typically a history of recurrent infections. And then of course, hyper IgE, so elevated IgE, and we'll talk a little bit more about that in a case presentation. So clinical presentations of B-cell deficiencies, these patients have recurrent sinopulmonary infections with gram-positive, gram-negative organisms, mycoplasma. They'll present with recurrent ear infections, sinus infections, lung infections, complicated by bronchiectasis or pulmonary infiltrates. They can have recurrent GI symptoms, so malabsorption, cholangitis, which you'll see with hyper IgM, lymphonodular hyperplasia, ileitis, colitis, infections commonly with Giardia, Campylobacter, Cryptosporidium, and often you'll see splenomegaly, especially with hyper IgM syndrome and common variable immune deficiency. Always check your patients for hepatosplenomegaly. It's a red flag. Uncommon manifestations. So meningoencephalitis, you can see this with enterovirus infections in XLA patients. Thoracic and abdominal lymphadenopathy, often seen with common variable immune deficiency. Cytopenias, including neutropenia, anemia. Lymphomas, often seen with common variable immune deficiency. Thymomas, good syndrome. So this is when you have like hypogammaglobulinemia and thymoma. Bile duct and pancreatic duct malignancies, again hyper IgM, and autoimmunity, rheumatoid arthritis, lupus, autoimmune hepatitis. These are seen in selective IgA deficiency and hyper IgM deficiency. All right, so let's run through a quick algorithm on diagnosis of antibody deficiencies. So you have a patient that comes in with recurrent sinopulmonary infections. If they have 2 or more infections, you want to kind of have increased suspicion of primary immune deficiencies. On physical exam, if you don't see tonsils or lymph nodes, you're thinking PID. If you do, then you want to consider it. Always do a CBC with DIF. It will tell you a lot. You'll look at lymphocytes and neutrophils, and those will kind of steer you in the right direction. After that, you want to do lymphocyte subsets. So you're looking at T cells, B cells, natural killer cells, quantitative immunoglobulins, including IgG subclasses, and then specific antibody responses. So we check tetanus because we're looking for T cell function. Pneumococcal antibody titers we just talked about. Sometimes you can also check for diphtheria or Haemophilus to allow you to understand a little bit more about T cell function versus B cell functional defects here. All right, so another quick case, hyper IgE. So this is a rare primary immune deficiency. It's characterized by recurrent eczema, skin abscesses, lung infections. On lab testing, you'll see hypereosinophilia and hyper IgE, so high levels of IgE in the hundreds to thousands. These patients have like classic facial features. So they have long faces, broad nasal bridges, and their eyes are typically very close together. They also have dental abnormalities. So on this x-ray, it's kind of hard to see, but you'll see 2 rows of teeth. So these patients, there's many different gene defects. The most common is the autosomal dominant one that you may remember from medical school. So these patients present with recurrent sinus infections, ear infections, and lung infections. The lung infections are typically characterized by infections with staph, but you can see infections with strep and Haemophilus as well. The healing of the lung parenchyma is abnormal, so pneumatoceles and bronchiectasis are actually hallmarks of this disease. You can also see infections with Aspergillus, Pseudomonas, non-tuberculous Mycobacterium, as well as dimorphic fungi such as Histoplasma and Cocci. And remember to keep in mind mucocutaneous candidiasis when you see these patients as well. So here's a chest CT, and you'll see evidence of bronchiectasis and a pneumatocele that actually has an aspergilloma in it. So in treatment of these patients, there's a lot of different things we can do. Stem cell transplant has been sort of variable. We've seen decreased levels of IgE and inflammatory cytokines with that, but we have not seen the dysfunction of the STAT3 mutation change in the lungs with stem cell transplant. So once again, it's variable. So how do combined immune deficiencies present? So T cells and B cells. So these patients often present earlier in life. So these can be skid babies, for example, presenting with failure to thrive, oral candidiasis, viral infections, diarrhea, dermatitis, hepatosplenomegaly, and then infections with opportunistic organisms. Here's a quick algorithm. So these patients may present, once again, with failure to thrive, viral infections, or unusual infections. Red flag for PID. On exam, once again, if you don't see tonsils or lymph nodes and you see dermatitis, think PID. If you do, then check your CBC with diff, and then if you're thinking T-cell defects and they're babies, do a chest x-ray, look for a thymus. On labs, what you want to check are your T-cell subsets. You want to do, so one thing you can do, and I don't know if you guys use Mayo or our root, but there are some send-out labs you can do to check T-cell function. And so what you're looking for is T-cell proliferative responses to common antigens and mitogens. And in office, what we do is delayed hypersensitivity testing. So we use the PPD as our control, and then we do intradermals to Candida and mumps. Read them 24 hours to 48 hours later. If the induration is greater than 5 millimeters, then you know your T cells are working. If it's not, you know you have a T cell functional defect, and you put that together with the rest of your clinical story. All right, so let's talk about the innate immune system disorders of phagocytes. So when a phagocytic cell meets a microbe, what happens is you have these proteins which include GP91 FOX, P22, P47, and P67. They all come to the cell surface, and then they have activation of the NADPH complex. What happens then is you have electron transfer, which creates a reactive oxygen species, which then leads to the production of hydrogen peroxide and then bleach, which then helps to kill the microbe. So defects in different ones of those proteins all have different genetic variants, right? And so what we see is the most common one is the GP91Fox, and that one is X-linked. We're actually diagnosing more phagocytic disorders because we have better testing now. So, for example, chronic granulomatous disease, you may remember this, the incidence is 1 in 250,000. These patients present with recurrent life-threatening bacterial and fungal infections of the skin. So these patients present with cellulitis, abscesses, like deep skin abscesses. In the airways, we'll see lung abscesses. We'll see suppurative lymphadenitis, liver abscesses, often with staph or aspergillus, brain abscesses, and osteomyelitis, often with serratia. If you see a patient with serratia osteomyelitis or staph osteomyelitis, please check for phagocytic function and numbers. So often these patients will have infections with catalase-positive organisms. So for example, staph, serratia, Klebsiella, Candida, Aspergillus, and Burkholderia. Those are all common organisms that if you see cultures positive for that, please think phagocytic disorders. These patients will also present with oral ulcers. We talked about osteomyelitis and abscesses. Cellulitis without pus. So this is an example of a phagocytic disorder where you have problems with adhesion or rolling of neutrophils or macrophages, monocytes. And what happens is it's sort of like a bunch of frat boys, right? They see something that they like, but they just kind of stand around and look at each other. They're not doing anything. So in cultures, it'll look like pus, and then you'll culture it, but you see no neutrophils. Then you also have granuloma formation, and this is because of an abnormal inflammatory response in phagocytic disorders. All right, so GI manifestations of chronic granulomatous disease. We talked about infectious and inflammatory problems. So infections, bacterial and fungal, remember that, don't forget the fungal infections. Inflammatory-wise, diarrhea, vomiting, oral ulcers, anal fistulas, rectal abscesses, intestinal obstructions, and ulcerations. So the key points here are that, for example, if you see anal fistulas, the reason that they don't heal is because of an abnormal inflammatory process. Okay, and then with the poor healing comes granuloma formation. So they kind of go hand in hand. Sometimes these patients will actually present with bladder outlet obstruction. So remembering, again, the variable presentations of patients with primary immune deficiencies. Quick algorithm, so if you have a patient that comes in with recurrent skin or soft tissue infections or recurrent pneumonias or liver abscesses, on physical exam, you're either seeing cellulitis, abscesses, lymphadenitis, hepatosplenomegaly, gingivitis. You do your CBC with diff. Here you're looking for your number of neutrophils. Then you're going to look for the oxidative burst. So you guys may remember the NBT test where you look at the cells, the neutrophils under the microscope, and basically if the oxidative burst is working, the function is good, you'll see a blue stain, and if it's not working, you see no stain. So that's kind of an old school test. We've graduated now, we're using flow cytometry, and so what we do is we look at the production of reactive oxygen species on flow cytometry, and this can help us to identify not only X-linked chronic granulomatous disease, but also autosomal recessive and carriers too. So, and if you guys have questions about that, we can go over that. But this is really, really easy to order. You just type it in as oxidative burst, and you can either get an NBT or a DHR if you're looking for phagocytic defects in your patients. You can also order CD11 or CD18, and this is when you're looking at adhesion deficiency. So if you're seeing kids, their umbilical cord hasn't fallen off yet, you're concerned about that, that's when you'd want to order CD11 or CD18. Or if they're older and you're seeing cultures that a purulent drainage with no neutrophils in there, that's another time you want to order that. All right, so moving on to complement. 3 things to remember about complement. Patients can present with lupus-like disease, especially in children. Neisseria meningitidis, we talked about that before, and then angioedema. So 3 things to relate to complement disorders. All right, so this is about the time where people's eyes start to roll in the back of their head, and I promise I'll make this as simple as possible. So there's 3 complement pathways, right? So the classical complement pathway is when you have antigen antibodies binding to microbes that can actually turn on or stimulate the complement pathway to create inflammation, or you can have direct binding of what we see C1q to the surface of the microbe to activate the complement pathways to create inflammation, to recruit cells, to kill off infections. The mannose-binding lectin pathway, so this is something, it's a normal serum constituent, and it binds to encapsulated bacteria, okay, to activate complement, create inflammation, fight infection. And then finally, the alternative pathway. So this is where the surfaces of certain microbes actually trigger certain components of complement to recruit inflammatory cells and kill off microbes. The final common pathway of all of them is C3, and basically the 3 functions of all 3 complement pathways are to recruit inflammatory cells, opsonize pathogens, meaning like this is immunologic ketchup. We're putting something delicious on these microbes to attract neutrophils, monocytes, macrophages to eat them up, and finally killing of pathogens, which may be either via phagocytosis or direct lysis. All right, so here's our algorithm for complement deficiency. So we have a patient that presents with either recurrent bacterial infections, Neisseria meningitidis, lupus-like disease in a kid, angioedema, or recurrent hemolysis. So if you have a patient who has the Neisseria infections, you want to order CH50, which is your total complement, that's going to be low, and C5, 6, 7, 8, and 9, and that will be low too. If you have someone that's presenting with lupus-like disease, order C1q, RS, C2, and C4, and those will all be low. You can also do send-out lab for immune complex by Raji assay. If you have a patient with recurrent pneumonia, order total complement, so your CH50, your C3, and your C4, and they will all be low. Patient with angioedema, C2, C4, and C1 esterase inhibitor in function. What I will tell you about patients with angioedema, and this is just an allergy clinical pearl, is that if you just order C4, it's 94% sensitive. So if your C4 is normal, it's probably not related to a complement defect. Patients with recurrent thrombosis or hemolysis, you can order CD55 or CD59, and those will be low too. So how do we treat primary immune deficiencies? There's a lot of different ways. We can use stem cell transplant, gene therapy, or biologics. Stem cell transplants typically more pertinent for the pediatric population, so patients with SCID, Wiskott-Aldrich, which you guys may remember is recurrent eczema, epistaxis, and immune deficiency. Chronic granulomatous disease, we just went over that, and hyper-IgM. Gene therapy right now is being used for SCID with ADA deficiencies, so a specific type of SCID, Wiskott-Aldrich, and then also now there's some evolution of gene therapy for chronic granulomatous disease. Biologic therapy, interferon gamma, is being used for chronic granulomatous disease in conjunction with triple therapy, so that's antibiotic therapy and antifungal therapy paired with interferon gamma. And what interferon gamma does in these patients is basically allows the immune system to work a little bit better. So better antibody-dependent cellular cytotoxicity and better function for our neutrophils. And then finally, immune globulin. So of all the things that we have time to talk about, let's quickly talk about immune globulin therapy. So immune globulin therapy can be used to treat a variety of disorders, X-linked agammaglobulinemia, hypogammaglobulinemia, common variable immune deficiency, SCID variants, IgG subclass deficiencies, and specific antibody deficiencies. So what is immune globulin? This is polyvalent immune globulin that has a greater than 90% of monomeric IgG with traces of IgA and IgM, has all of your IgG subclasses, and a wide range of specific antibodies. Why is this important? Because we're actually replacing what your immune system is missing, and that's why this works. So this is plasma. It's derived from a large pool of donors, and then it's nanofiltrated to remove infectious components. So there's a theoretical risk of infection, but there have not been any documented. How do we dose IVIG? So it's typically weight-based, anywhere from 300 to 800 milligrams per kilogram. People often ask, what is the dose that you want to use? So we're treating the patient, not the number, okay? So we usually, depending on who you talk to, people will start at anywhere from 400 to 600 milligrams per kilogram, and then you'll check IgG troughs or IgG numbers about once every 3 to 4 months, and you follow the clinical picture of the patient to figure out what is the best gene number for them, and we can talk more about that if you like. All right, so we used to use chicken soup to fix everything. Just figure that IVIG is the same idea. So here we go. So there's different modalities of treating. There's IV, there's sub-Q, and then there's enzyme-facilitated sub-Q. So let's kind of review briefly the differences between IV and sub-Q. So with IV, basically we can use one site to infuse large volume of immune globulin, typically once a month. The downsides here are that you need venous access. Because it's going directly in your bloodstream, you can have a high risk of systemic side effects. And these infusions tend to take a little bit longer than the subcutaneous infusions, anywhere from 3 to 8 hours approximately. Subcutaneous, patients can actually learn how to do this themselves. Doesn't obviously require venous access. Typically, with conventional subcutaneous therapy, you can only infuse small amounts of volume per site. Therefore, you end up using multiple sites for infusions. However, there are some higher concentrated versions of subcutaneous therapy which allow us to infuse larger volumes per site. And then if we're using enzyme facilitated, we can actually use very large volumes per site. The one thing to remember about subcutaneous is because it's not going directly into the bloodstream, the therapeutic IG has to basically go into the lymphatic tissue and then gets absorbed. So the bioavailability can be different. All right, so people always ask questions about the enzyme facilitated just because it's kind of new and interesting, and so I thought we might review that a little bit. So in general, when we're thinking about subcutaneous tissue, we know that we have a matrix of collagen, elastin, and hyaluronin, and this limits the amount of volume we can infuse in one spot, right? So that's why with conventional subcutaneous therapy, we're limited to about 15 to 30 mLs per site. With enzyme-facilitated IG therapy, what we use is hyaluronidase, which temporarily breaks down the hyaluronin. And hyaluronidase, as we know, is already present, in us and basically functions the same way. We're just targeting it in one spot. So we use hyaluronidase to create sort of a pocket to allow a large volume, basically 1 month's worth of a therapeutic IG to be infused at one site. And because of this process, we actually have a bioavailability and pharmacokinetics that are very similar to IVIG. So we can then use large volumes to infuse once a month, just as we would with IV. But because we're infusing it subcutaneously, we have less systemic side effects. By systemic side effects, I mean headaches, myalgias, flu-like symptoms. And because we're using hyaluronidase, as I mentioned, the bioavailability is a little bit better, so the efficacy and the tolerability is similar as compared to IVIG. In studies, there have been no changes long-term in the skin. And one thing to remember is that this has not been studied for pediatrics. There are other versions of subcutaneous therapy that are well studied for pediatrics and approved for pediatrics. So this is just not one of them, though. All right, so side effects. With all the good things come the bad things. And so if you're gonna think about prescribing something like this, you kind of wanna know what to expect. So some of the mild side effects include headaches, nausea, chills, flu-like symptoms, and these are typically mitigated by pre-medicating with either Tylenol or Advil. You can prehydrate these patients, and then you can also change the rate of infusions. Some of the rare but important side effects to keep in mind include aseptic meningitis. So basically the patient within about 24 to 72 hours after an infusion will complain of like the worst headache of their life. This is typically associated with high doses, so either patients or prescribers that are dosing on the 800 milligrams per kilogram or patients that are using IG therapy to treat autoimmune disease like ITP, for example, where you're using like 1 gram or 2 grams per kilo. This is treated basically with IV hydration and steroids, and then at that point you're probably going to switch from an IV prep, which is usually when this happens, to a subcutaneous prep. Thrombosis can occur also, so this can occur in the absence of risk factors, but is seen in patients who are either on oral contraceptives, patients who have cardiovascular risk factors, patients with prolonged immobilization. These are just things to keep in mind, especially if you're prescribing and you're talking to patients about risk, benefits, side effects, and alternatives. Renal dysfunction. So immunoglobulin therapy can actually cause proximal tubular damage. Typically, once again, this occurs with IV and high doses and with older preps that actually used sucrose and maltose. Nowadays, most of the therapeutic immune globulin does not use this as preservative, so we don't really have to worry about it, but you need to keep it in mind. What you can do is just prehydrate and drop the rate. Anaphylaxis can occur, so you want to make sure that you're checking your IgA in your patients. If the patients are IgA deficient or depleted, basically switch to a low IgA prep. Remember that because you're getting antibodies from other donors, you may have false positives when you're checking serum. And in summary, primary immune deficiencies are not rare. Please keep this in mind when you're seeing these patients that are coming into your office with recurrent infections and all the other presentations that we talked about today. Thank you very much. In the interest of time, I'm going to stop.